Thank you, Amy. And finally, we have the opportunity to bring up Lauran Hardin with the Camden Coalition. Looking forward to her sharing about innovation in this space. Lauran.
Thank you very much. You've heard a lot of really important data and information about the problem at hand and the critical need to really look at community-based solutions and investment in this workforce. I have the privilege of getting to talk about innovations that I'm seeing happen around the country and close it out with some stories of hope. But first I want to talk about why I care about this and who taught me the most about this, the importance of this. When I was 12 years old, I woke up one day and my mom was blind. We found out very quickly that she had a very rare form of MS that was a waxing and waning kind. And so at 12 years old, I became the caregiver in my immigrant family for my mom. And she continued to have MS for another 40 years until she died of dementia. But she was a tremendous teacher to me about the importance of the community network, our integration of care teams, and how we support patients and families through this. My second teacher was my niece, Anna. At 9 months old, she was actually diagnosed with a very rare genetic condition. So this was a lesson about what happens for children who are complex with serious illness. Anna was a tremendous gift to our family. All of us needed to surround her with a circle of support, and she died when she was 2 years old. What we learned from that was how important the workforce, the community-based support, and the integration of the family was in that care. And then my third teacher, and most recent and important one, is about 6 years ago, I became responsible as an advocate for a family member who's bipolar schizoaffective. This was a new lesson in what serious illness means. I watched with him the challenges of what it is to have an illness where you can't really read and process the paperwork that's required to do for you to get food benefits or to get insurance, where you can't really get a job because your illness gives you a perspective where the normal constraints of a job are not something you can meet. And then what is it to form a sense of meaning if you're physically healthy but can't get a job and are not like other people? So he is my best teacher about the importance of the workforce and our attention to serious illness and the structures around that. So now for the entertaining part. I work for the Camden Coalition now, which is focused on complex health and social needs. And one of the things that's been already mentioned this morning from Michelle is 5% of the population actually represents 50% of the costs in the healthcare system. So I've been working and focused on this 5% really deeply for the last 10 years. My background includes hospice, children's hospice, palliative care, and then solely complex care for the last 10 years. This population is very diverse and is a great teacher about what needs to happen in our system. In Camden, they identified this population really as outliers. So if you look at the data, this outlier population with high cost, high needs really is experiencing a mismatch between the services that are offered and the needs of the population. And there's great lessons in this group to learn to really shift our healthcare system. The definition of complex care is really kind of an emerging definition in the field, which is complex populations or complex care seeks to really integrate care and the well-being for this small heterogeneous group of people. And these folks often intersect with multiple services across the community. It's not just healthcare, it's not just behavioral health. It often can involve the criminal justice system, public health, many, many services. So it's really understanding how to create an integrated system of care. So with the Camden Coalition, we've had the opportunity to be funded to create a national center for complex health and social needs. And that's when I joined the coalition. I work with people across the country who are looking to build programs. But our vision is to really build an integrated, transformed healthcare system that ensures everyone receives whole person care rooted in authentic healing relationships. And our goal in our work is to really spark a field and a movement that unites communities and builds capacities for this population. So we do this in Camden and working with individuals and really kind of looking at it from an ecosystem approach. For people who have serious illness or complex needs, it's not one system often that's going to solve that. And really our collaboration and coordination with each other is where we're going to find real efficiency and improvement in delivery. So in Camden, we have a community-based model. It's a combination of LPNs and community health workers, primarily, who visit with the highest cost, highest needs folks in Camden, right in the community. They're supported by a nurse and a social worker, but the main care is delivered by a community health worker and LPN, as well as peer navigators. So some of the people that we've cared for who are homeless are actually now on our team. Also, some of the folks who had opioid overuse and addiction are now healthy and on our team. So that peer navigation role is really, really helpful in delivery. Our model in Camden is focused on daily triage, so really using data to find the highest risk people, and that's performed by someone who's not clinical. So you can do that with an algorithm to target the population. Then bedside engagement, so really reaching out to people to see if they'd be interested in support. Very patient-facing care planning. So this is Michael. When they reached out to Michael in the hospital, what they did was give him a sheet and have him identify what he wanted to work on. So Michael was very near end of life from addiction and devastation of his liver. And really what you'd think is his first priority would be, how do I stop the addiction? How do I heal from that? But if you could see that list, the first thing Michael wrote was, I need an ID. I might want to go back to school. I need help with a different kind of housing. None of it was about medical things. And then after the care planning, we engage people in the home with community visits. There's a coach model in Camden. This has been very helpful for teaching patient engagement and on a different level. So how to start first with what matters most to the patient, and then really focus on building authentic healing relationships. So the intervention's driven by what matters most to the person. There's different core competencies that are emerging is really critical for complex populations. So things like motivational interviewing or trauma-informed care, understanding that a history of trauma as a child affects your health and perspective later. And equally as important, a history of recent trauma or grief and loss is really critical to address in serious illness in complex populations. So we had patients identify the domains that mattered most to them. These are what patients identified in that study. Most of them are non-medical, so it's really important for us to start to integrate this. We have practices in our team, so as you can imagine, if you're focused just on the most complex people, that can be very hard on care teams. So this is our team dancing, which they do every Friday in the morning. Every morning we start with a huddle. There's some activity to link people to the perspective of you're part of a team. We care about your resiliency. So it might be a meditation, it might be a poem, it might be dancing, but there's a moment where people come together. Then there's also case conferences, so integrating all disciplines in a supported environment on a weekly basis so people can learn together and feel supported in carrying the work. And then we also have really rigorous behavioral health benefits. So our physical health is important, but for people who are in the home doing this complex care work, that information is critical. I work with sites around the country now, co-designing models for this population. One of them is in Lake County, California. It's a wonderful place for innovation. It's very far north. There's a lot of fires in the county. There's high poverty, some of the worst health outcomes. And the county decided they wanted to do a collaborative model for complex populations. So we built a collaborative called Project Restoration, which includes police, fire, EMS, social services, behavioral health, all agencies sharing data to identify their most vulnerable community members, reaching out together to intervene, and then doing process improvements for the community based from what they learn. I want to show you them talking about it because it shows you the possibilities of new partners in delivery of serious illness.
A year ago, I was homeless. I went through divorce, depression, alcoholism. It started so fast that there was no going back, it seemed. When you're homeless and when you're using and drinking, you neglect everything. One of those nights that I was drunk, I got hit by a car. I was walking with a broken hip. I was close to dying and I really didn't care.
A lot of times by the time we show up, it's gone way beyond what it should have because they really don't want help.
Just this last year, we did 27,000 incidents, and you sometimes don't think about what led up to that situation.
And the story starts with a lot of desperation, sadness, hopelessness.
From homeless to getting sober, then now what? You know, I didn't have a plan B.
We need to fix the broken system.
What can we do that is going to have a county-wide impact?
If we can break that cycle and give them a little bit of help to get them back on track.
If we can coordinate all the services that are available and have them work together, it will be far more powerful.
The question ceased being what if to when and how.
Restoration House is a place for people who are experiencing significant medical issues and are also homeless or at risk of becoming homeless. We provide intensive case management, a safe place to heal, and also a place where they're accountable for their choices and their actions.
This was something different. To change the whole concept of healthcare and caring for individuals. If we don't have a house, and we don't feel safe, and we don't have food, then we're not going to be healthy.
When they come into the program, I sit down with them and I talk about where do you need help? And we walk them through the process of what they need to do to get well.
From here, the goal is permanent housing, but we walk along that path with each resident so that they are ready when it becomes available to them. Change is possible.
A program that reaches out to them and makes that first move can make an impact.
To see that individual later on being a productive member of our community, having a job, treating their kids properly, treating their family properly, that to me is tremendous.
This is a new beginning.
I just finally had someone that had faith in me. Restoration House has given me everything. Having my kids say they love me, finally.
You can't change the past, but you can change the future. And together we are doing that.
So you'll notice in that video, there's pretty much every discipline you could imagine working together. It involves people who are homeless, but also lonely, isolated older people. It involves many vulnerable older adults with the most complex needs. And by collaborating, they're seeing amazing outcomes. In the first, I hope this doesn't play some weird ad now. Who knows what's coming next? Can you advance the slide? Okay. They had very, very strong outcomes with the first 28 patients that were served. There's a peer-reviewed article that came out this week about it. This is only one component of their program, but by collaborating and really looking holistically at that person-centered story, they're seeing really strong results in building an ecosystem in the community of services. So we've learned by doing these models, it's very, very helpful to look at who are your potential partners and the existing assets if you want efficiency in the delivery. And it's also very helpful to start with the people and their families and ask what matters most to them in the design. From a policy perspective and competency perspective, teaching people to really address social determinants of health is critical. I didn't realize when I was working in the hospital setting, I was sending people home with the diabetic management program when they didn't have a fridge to even store their meds. Or I was setting people up for follow-up appointments. They had an address, but really they didn't have a house. They were couch surfing, and they had no car and no way to get there. If we don't start looking deeper, our ability to really serve the needs of patients and families with serious illness is not met. And then people have mentioned this already, really starting to pay for other disciplines that are not billable right now is what's shifting delivery. So many free resources for you to continue understanding this innovation work. And I want to thank you very much.